Good morning, everybody. I am Trevor Henderson. I am with the National Metro Health Public Health Department. I'm the director of our overdose response and reduction program. And Josh Love, who is the epidemiologist on our team, is co-presenting this. Well, I say co-presenting, I'm making him do most of the work. Very quickly to frame this, we're very happy to be part of this. I've been aware of One Tennessee for a while, and several years ago when I started working on this issue, we were certainly looking at an overdose crisis that was driven by prescription opioids, or at least that's what it looked like in our data. And we have seen that morph and change, particularly in 2018. We've seen it really switch over to driven by illicit opioids, and also now seeing more and more stimulants coming into play also. Part of what we try to do is monitor and do surveillance on that and try and keep on top of the trends so we know what's hitting our communities, and trying to then tailor responses where we can based on the data that's available. As part of that, Josh has been instrumental within the past couple of years in getting a surveillance system up and running for public health in Davidson County. We're obviously working with Tennessee Department of Health and the HIA folk on trying to help and assist there, get this approach replicated in other counties as much as we can, as well as learning from other counties and what they can do. So for this, Josh has more than several slides to take you through a sketch of what we're doing for trying to monitor this, and then how we try and turn that data into action. If we can hold questions until the very end, we'd be more than happy to talk to people then. Josh?
All right, thanks, Trevor. Again, to reiterate, we appreciate you guys having us on board to talk about our work here that we're doing in Nashville and other parts of Middle Tennessee. So I'm going to present essentially how our surveillance system is structured, what we get from it, how we conduct routine monitoring, and how that helps us to stay on top of emerging activity and trends that we see. So a little bit of background, as I'm sure we're all aware, the overdose epidemic, especially in Middle Tennessee and Nashville, has been increasing over the last few years. Therefore, it was crucial for us to stand up a surveillance system to implement routine monitoring and analysis. And so our system that we currently have integrates multiple data systems for both fatal and non-fatal overdose activity. So just a brief refresher on those of you who are unfamiliar with public health surveillance. What is it? It's the ongoing collection, analysis, and interpretation of health data. We use this for prevention and control. And an effective surveillance system allows for timely dissemination of information. We're able to understand the magnitude of a health condition, the history, the ability to detect outbreaks, how the health condition or disease is distributed or spread. And this helps for us to inform control strategies and identify any, again, emerging trends, in particular this case, emerging substances. So to develop a drug overdose surveillance system here in Nashville, we identified and integrated all available data systems that cover overdose activity, incorporate consistent definitions and metrics so we can compare trends over time and be able to compare to other areas in a similar fashion. The API piece, we won't get into that. That's a little techie, so let's just ignore that. But then once we implement this surveillance system, it really allows us to monitor, detect anomalous or acute increases in overdose activity, and then again to turn that around and report it to our internal, external partners in the community to inform prevention and control strategies. So a high-level overview of our surveillance system, we break it down into primary, secondary data systems along with applications that we utilize. And so for the primary data systems, we're talking about our local medical examiner data so we can stay on top of fatal drug overdoses. Those drug overdoses reported by hospitals. Since 2016, drug overdose is a reportable condition in Tennessee. So we have access to that data system per Tennessee Department of Health. Syndromic surveillance, which is essentially emergency department activity that's occurring in the county. And this is a nationwide surveillance system that we utilize in Tennessee. And then also we have access to our local EMS data. So anytime there's a suspected overdose occurring in Davidson County, we have access to those data. And with that data system, it's connected to ODMAP, which is the Overdose Mapping Application Program. It's a nationwide near real-time surveillance system that public safety and public health utilize, and we have it here in Davidson County. It allows us to really stay on top of emerging activity. So what do we get out of our data system? Again, routine monitoring analysis. We're able to understand characteristics and trends of fatal, non-fatal overdoses. That includes baseline activity levels. So we're able to see when we might breach thresholds and where we have an alarming number of incidents occurring within a specified time frame. Temporal and geospatial trends. And then which groups are primarily affected based off of demographics. It aids us in the detection and response of activity. So it really gives us a foundation and really formulates the foundation of our acute overdose response plan that we implement in Davidson County. And then, of course, routine reporting to internal, external partners is appropriate. We have a lot of weekly surveillance updates. We have a public-facing quarterly report on our health department website. And then we also utilize these data for data to action initiatives, especially with our prevention partners, and we'll get into how we do that a little later on. So for our acute overdose response plan, it can be broken down or overall into the following process of, we have detection channels such as ODMAP, our emergency department activity, and then we have a program phone and email so we can capture any activity that's occurring. So once we detect these potential alert level events, our program epidemiologists then go through and collect and analyze all available data sources. So for example, if we detect an increase in emergency department visits related to overdoses, we would then go into that system, extract that data, and then also look into our EMS system, look into our medical examiner data over the same time period to see if there's any correlations or if non-fatal overdoses are resulting in fatal overdoses, for example. Once we collect that data, we generate a situation report and then review that with our team to determine next steps. And that could be, keeping that internal. If maybe there's only a select number of partners that the information is appropriate for, we go down that route. Do we need to escalate any communications to the public that could potentially reduce any further harm? And then, of course, afterwards, we continue to monitor the event to see when it may end. So there's definitely a tiered response that we have here in Davidson County. And this is a high-level overview of our communication channels. Of course, you see public health, medical examiner, public safety, local hospitals and emergency departments, and then our treatment and prevention folks. So we're always looking to get that information to anyone we can for whom it might be applicable and it would be helpful information. And so one of the data action initiatives that we are currently implementing is with our prevention partners, those groups that are distributing naloxone in the county. And so we utilize ODMAP and other mapping systems to essentially point them in the right direction where we find cluster activity. So we review this on a monthly basis with them, and we're able to again analyze clusters so we don't, unfortunately, this crisis is happening all over the county, so we really have to hone in on where the high activity areas. So that's a standing meeting we've been having for several months now, and I think we've had some success with it, and we're really hitting our stride with communicating that information to them, and then subsequently them going out into the community. I didn't know, Trevor, do you have anything you want to add on that at the moment?
I mean, I would just quickly mention, we have also shown ODMAP to some homeless service providers in the community. And again, they're very enthusiastic in engaging with us in areas that they can identify homeless camps, so that we can really help them know when to target their services and their outreach. So So we're at the very beginning stages with that. But that's another potential collaboration that we can use with this.
Okay, so as part of the monitoring, I'm going to go through some current trends that we're seeing. And so overall, and the figure on the right shows our suspected fatal overdoses over, between 2016 and 2017. As you can see, we've had an increase. We've increasingly detected fentanyl in toxicology reports from the medical examiner. Last year in 2020, it was almost 80% of overdose-related toxicology reports had fentanyl, compared to 2016, where that was only 20%. So we've seen a dramatic increase, especially with regards to fentanyl. Meanwhile, we've seen a shift away from heroin and prescription opioids, I believe, as Trevor said in his opening remarks. So especially 2020 was interesting to look at, given we had the pandemic that's kind of still occurring. We were projecting about a 15 to 20% increase across these data systems, given the previous years at that point. However, we saw more along the lines of 30% increases. So it was a very active year, very deadly year with regards to overdoses. So one thing we do monitor is trends in substances that we detect, especially from the toxicology reports. We can also monitor this activity to an extent with our emergency department data, but primarily we do this through our toxicology reports. And again, to reiterate, fentanyl is the primary driver of fatal overdoses in Davidson County. But we're also seeing an increase in stimulants such as cocaine and methamphetamine, as well as benzodiazepines. I'm sure we could talk a lot about just the number of substances we try to monitor. I think we'll get into that a little bit, but yeah. And then again, the figure on the right is just another representation of fentanyl is in red, of how that is, as Trevor was saying earlier, crossed over, especially towards the end of 2018 and beginning in 2019, where it really comprised the majority of what was detected in our toxicology reports. Also worth mentioning are fentanyl analogs. For those of you who are unaware, they're chemically related to fentanyl. They mimic the effects, but they vary greatly in potency. For example, carfentanil is 50 to 100 times more potent than fentanyl. So we keep tabs on that. We've detected 10 different fentanyl analogs that have shown up in toxicology reports in Davidson County since 2016. Nationwide in 2020, there were 3 novel analogs linked to multiple deaths that were reported. Fluorofentanyl, one of those we have detected in Davidson County, I believe, beginning in September 2020. And then, we, of course, receive information from other jurisdictions across the country, and especially fluorofentanyl seems to be very popular in the first quarter of 2021. So we're wondering if that will then show up more so in Davidson County. But the emerging, especially with fentanyl analogs, is an emerging trend we really try to stay on top of, and it changes quarterly with what's popular. These two maps, well, there's going to be this slide and the next slide are going to show zip code level maps. This is our EMS data. So anytime there's a suspected overdose, this is by zip code of the incident. And as you can see, if you're familiar with Davidson County, we definitely have seen in 2020 compared to 2019, just an overall increase across the county, but then also in these eastern zip codes, we've seen those creep up and going into the first quarter of 2021 as well. So an increase in activity over here, in addition to our normal hotspot areas. And we see that as well with our fatal overdose data. If you can compare those two maps there, and you can see some zip codes are starting to emerge. So briefly, where are we in 2021? Here locally, we're keeping pace with our EMS, overdose-related EMS runs. Overdose-related emergency department visits are up compared to the same time period last year, as well as our suspected overdose deaths. We're continuing to see a shift away from the shift towards non-heroin opioids and stimulants. We have, as I said earlier, emerging zip code activity in addition to where we normally see activity. And this slide's breaking down the main substances that we detect in toxicology reports and comparing them to last year. So as you can see, fentanyl is about 77% of overdose-related toxicology reports in 2020. So far this year, amongst available toxicology reports, it seems to be keeping pace, a slight increase with cocaine, benzodiazepines. As you can see, heroin is just off the radar almost. It's been a dramatic decrease that we've seen. Oh, that's it. Okay. Anything else you want to add, Trevor, at this point, or we'll take questions?
I think, yeah, I talk about this quite a lot when I started working on this in this issue in 2017. It was already a complicated issue, and I know Dr. Reagan was working on some of this at the time as well. And overprescribing was part of that issue. I mean, I think dealing with overprescribing, you had things like the CSMD. You could go in and find out who was overprescribing and try and work with them to try and change those behaviors. And I think there was success there. Once things started shifting over to more and more illicit substances, that complicates everything for everybody. Obviously, there is no database for fentanyl dealers. So trying to find out where these substances are coming in, when they're coming in, how that'll impact the community, that's all very, very tricky. Certainly, we have looked at the National Drug Control Strategy and really looked at where it talks about the importance of both public safety and public health working together on this issue, which is great, and we agree with that. The problem is there is no roadmap for that. So forging those relationships with public safety agencies to make for meaningful and an appropriate sharing of data to try and address this issue is quite a huge lift in its own right. I think with the prevalence of fentanyl in the community and the fact that it seems to be going nowhere quickly, I think those strategies are going to become more and more important, really trying to look at the illicit part of this, tracking with it, looking for those changes, helping our ropes in the community and other prevention agencies figure out, well, what substance is exactly hitting our community and when, what kind of danger are they in? There is a lot more work to be done on that front, and unfortunately, it doesn't look like it's going away anytime soon.
Well, and I would add to the public safety, public health data piece, Trevor, we talked about this, is where other areas have shown the correlation between drug seizures being potentially predictive for the types of substances involved in overdose deaths. So that's, again, to reiterate how we're trying to build up the public health or public safety data side and subsequent sharing, so we can maybe, again, get out in front of what might be coming down the pipe. So.
Yeah, well, does anybody have any questions, thoughts, criticisms, complaints? We're open to it all.
Wonderful presentation, gentlemen. Thank you.
Thank you.
And this is David Reagan. I do have a couple of questions. It was a wonderful presentation, and I really appreciate how you organized everything and made it easy to see how things work. And you've answered some of this, but in looking at the timeliness of the data, is it what is the lag time between the event, say, the overdose or overdose death, in the data getting to you? So some of it seems to be almost near real time, but then other pieces of data seem to be maybe delayed longer than that, especially with the deaths. How do you see the data and the timeliness of the data?
Josh, this is all.
Trevor, I was going to kick this to you. No, I'm kidding. No, it's a great question, and I left that out unintentionally earlier, but the data systems that we use for our surveillance are very timely. EMS is near real time. What's mapped into OD map is, so the way OD map works is when the EMS makes the run, and then subsequently after the run, they log the information into their data system. OD map refreshes on a routine basis, so to then upload it. So that's very timely. We're talking a few hours. Our syndromic surveillance through the emergency departments, that system lags about 2 days. So that's, in terms of public health, that's very timely. All these are.
Yeah.
Our reportable disease database, I believe that has about a 2.5-week lag. And then our medical examiner data, it's as soon as they input it in the system as well. So we're usually, I mean, like our program, we're usually waking up in the morning and checking the, the medical examiner database to see what kind of activity we had from the previous day, see if there's any increases there. So again, very timely data systems. And we found that, I mean, they've been very useful. So all the information that they're providing has been validated, and it's fairly accurate given the quick turnaround and the nature of these data systems that we're dealing with.
Josh, what's the current rough delay on toxicology from the medical examiner, though?
Yeah, thank you. I've left that out. So with our local medical examiner, when there's a death reported and they log it into the database, the toxicology reports aren't available at that time. I'd say there's anywhere between a 4 to 8 week lag. And I think that's typical throughout the country for how long those results take to get sent and brought back. We're aware of our public health colleagues in Seattle, who they got funding. So they were able to fund for on-scene analysis, which is really cool. But we don't have that here. So we're left with those deaths that might have been occurring from the day before, going through the actual case summaries. And those can be informative as well, but they're not toxicology results. But they do often, more often than not, mention which substances were encountered at the scene, any paraphernalia, so we can get a good idea of what was involved.
Thank you. That was really helpful. I was just really intrigued by Trevor's mentioning of reaching out to homeless service providers, when the epi, seemed to indicate there was an uptick in activity in their area. Do you envision any other partners that, that might be a part of response to this really almost the near real-time data, most of it, to allow more rapid response on the part of maybe other non-public health entities toward an uptick in a particular area?
I think the answer is yes. And I think Josh goes to great pains to sort of remind everybody, we started out very conservative on the sharing of data on this, just to try and make sure that we are not putting anything out in the community that could accidentally end up stigmatizing a community. So we want to make sure that the partners we're working with are truly on the ground and responding in the right way. And all of a sudden we don't see some of our OD maps all on Twitter and people then complaining about a homeless camp in their neighborhood, something like that. But yeah, we're kind of, I guess we're always looking out for those opportunities to expand into the next groups of people and partners who could respond on the ground.
Yeah, and I would add, we're definitely, it's been quite a trial as we go to communicate all this information that we're analyzing and so forth. When we go to send it out to partners and perhaps the public or the community, we want to put out actionable information. And so that's been, for us, epidemiologists, when we see something that breached 2 standard deviations of baseline activity, for us, that's, hey, we should communicate that. But of course, what we get back from our partners is, well, what do we do with this? So we're very wary of what we send out, and hopefully it can inform action, as opposed to, a simple increase in activity is not helpful for people. We just get a thank you, but is there a particular substance involved, a particular demographic, so on and so forth? So we're really, again, trying to tailor that messaging.
Do all the hospitals report to you in Davidson County?
They should. So for syndromic surveillance, to my knowledge, all major hospitals now report. I think the VA is kind of a tricky case, but previously it was like in 2020, going into 2020, we were still not having General and Vanderbilt, but now they're all on board. So we have everybody. And then reportable disease, that's reportable by law. So everybody should be.
And just maybe related to that question, I think this is where having the EMS data is also helpful, because we can get a sense of how many people refuse to go to the emergency department also. So if we were relying simply on emergency department data, obviously we're not capturing everybody that we need to be trying to pay attention to. So it helps round out that picture more.
Maybe I missed it, but did you say you can also tell how much naloxone was utilized, like on a run or?
Yeah, so there's different ways we can do that. OD map, not to, put out a ad for them, but their system, whenever they log or extract the data from the EMS system, it automatically calculates. So from that, they do whether a run was no naloxone, naloxone single dose, naloxone multiple doses. And then of course, we have access to that data as well. I'm always trying to see which, what's the mean number of administrations per incident, which we have seen that go up over the years, as I think we would all probably expect. But that's an interesting one as well, and trying to see what that means aside from the obvious.
And in addition to that, where we work with Tennessee Department of Mental Health and Substance Abuse Services to look at their records for naloxone distribution and then compare that to where we see overdose activity to, again, try and make sure that those distributions are being targeted to the right areas in a timely way.
This is David again with another question. I don't want to ask too many, so I'm going to wait after this one for a while. But I think the observation was made by both Trevor and Josh that the illicits are such an increasing difficulty here, and you can't use the CSMD to help you there. And it brings up this issue of interface with law enforcement / public safety. There are just so many potential difficulties in communication, and especially timely communication there. Do you, what do you see in the future, or do you see possible ways around some of the historic difficulties in that area in trying to get further, upstream of the actual overdose event?
Yeah, that's a great question. There is a model in New Jersey that the state police have up and running called the DMI, the Drug Monitoring Initiative. That we're kind of talking to them a little bit. It's really interesting because it's law enforcement initiated, and it's them trying to figure out how to engage with public health. Whereas we're kind of on the other side, we're public health trying to figure out how to engage with law enforcement. They put out a lot of reporting on the substances that they're seeing. They send out a weekly report with the street name for the drugs, with what was in it, just all their analysis. It's very impressive. They realize a lot of their data is very sensitive, so they're very careful about how they do that. And to get access to their information, I actually had to sign up for a Homeland Security Information Network account, which is a first for me. But they have utilizing this Homeland Security Network where they can put all of their reports. To sign up for this, you got to go through a screening process and justify why you need access to it. I think it's a really good model of showing that there are potential ways to address the barriers of information sharing while still protecting a lot of that information appropriately. So we've been talking with them a little, and would love to maybe try and get them engaged with talking with some of our law enforcement folk to see if there are ways to replicate some of that approach to make some information sharing easier. We have had a fentanyl work group hosted at our health department for over a year now. which is a regular meeting, and it's TBI, DEA, U.S. Attorney's Office, the DA's office, Metro Narcotics, really focusing on the fentanyl issue and trying to share information where we can, without crossing any boundaries that we shouldn't be crossing. Again, there is no roadmap for this, so it requires a lot of figuring it out. But I do think that just the nature of illicit drugs being the driver of this issue, we do need to figure out better ways for public health and public safety to engage on this issue. I don't think we can avoid that. So, Dr. Reagan, if you want to get engaged in that effort, I think I just heard you volunteer.
I didn't exactly hear that, but I appreciate the vote of confidence.
Do we have any more questions?
I'll throw a quick one out there. It's absolutely fantastic that you have access to all of this great data. Do you mind describing your experience of getting that access? Thankfully, I'm in the OD map's not an issue, but if I were interested in setting this up in my own county, what would that process be? Or even getting the DOR data, is that easy? Or do you have to have an epidemiologist in-house?
I think this might require both Josh and I to respond in different ways. I can tell you, I mean, I can only speak to Davidson County experience. I think one thing we do know already is that every single county is different and has different resources, and their first responders are set up in different ways. I spent a good year building up relationships with our EMS services with the fire department. And it was very obvious on the first few meetings that they were very reserved and did not want to share any information, didn't know what we were going to do with it. So it took a while to try and shift their frame of reference to more of a public health perspective and showing that their data could actually potentially eventually drive down some of their numbers that they were having to respond to, and more importantly, save lives. Where we are with our EMS partners now is completely different. They're totally on board with us and very passionate. In Davidson County, we have a post-overdose follow-up service going through EMS. So they are now calling clients that they believe may have overdosed. So within 48 hours, they're calling them back, checking in on them, seeing if they want any further assistance, and trying to do a warm handoff referral to treatment if that's what the person's ready for. So yeah, the relationships part is huge, and that takes time. I think it's the same with our law enforcement partners as well. They're used to their bubble and sharing information inside their bubble. So helping them see why sharing with public health is important. And also, in our case, what they can gain from our surveillance. So our Metro Police now have access to ODMAP. So they are able to use that appropriately for their services. And again, it's not for prosecuting or trying to hunt people down or anything like that, but they are able to use that in their surveillance as well. Josh, on the technical end of things, do you have any comments about how hard it is to get access to Essence or any of the other systems?
Well, no, I mean, with Essence, working as an epi at a health department, Essence is, statewide syndromic surveillance. So that's pretty straightforward, and, filling out a form or, asking for access. Same thing with our reportable disease. That's a public health data set. Here at Metro with our medical examiner, that's a contract we have with them to have access. But that, again, that's different, throughout different counties in the state. With EMS, it was just, to Trevor's point, just building the relationship, showing that, we're not doing anything nefarious with the data, and that it was really just helping just, demonstrate the burden and the magnitude of this epidemic. So they, it shows everybody else how busy they are in particular.
And as to the point of, do you need an epidemiologist? I mean, no, in some cases, but does it help? Yes, it does. And I think we, at the very early days of my role, we talked to the community, and I think that's something we heard loud and clear was we need data. We have great service providers, but we need to know when people are overdosing, where they're overdosing, how do we get to them, what's going on, run that picture out for us. So we, through the grants we applied for, we invested heavily in epidemiologists on the team. They aren't the type of epidemiologists I'm used to working with in our public health department, where it's a much longer turnaround on reports. This is rapid response. Poor Josh will get a request in the morning and be expected to turn it around within hours sometimes if we get a spike. He and Haley, our other epidemiologists, will have a situation report written up that morning, which we can then talk through as a team and then see who we need to communicate with in the community. Certainly, I'm not an epidemiologist. Could I do some very basic analysis on stuff? Yes, I could, but nothing like what a trained epidemiologist can do. And again, we're also trying to figure out how our public health epidemiologists could engage with law enforcement data and roll that into this whole piece as well. So yeah, helps to find yourself an epidemiologist.
Do we have any more questions?
I have, this is David. I have one more. If I'll wait for if someone else has a question, because I've already asked several.
Go ahead.
I just wondered for both Trevor and Josh, there've been much made of the links of the pandemic to what we've been seeing in the epidemic. Have you looked at this in a specific way, and or if not, what's been your sense of it as you're immersed up to your eyeballs in this, in Davidson County?
I'm going to let Josh answer this one, at least first, because he's worked on both ends of this crisis. So,
Yeah, I mean, so the further we get out from COVID, I think for us here locally, if we all remember kind of the beginning stages of COVID last year, primarily between the months of March and June, it's when a lot of the, lockdown orders were being issued. A lot of societal anxiety, if you will, just everything associated with the pandemic. The further out we get, those particular months were very active. So when we did some just predictions for 2020, those particular months really stood out of, increased activity from what we had previously projected. Can we draw a direct correlation between the two? I won't. Because we can't really connect those data sets, but we can stand back and look at the temporal sequence and say, yeah, something was definitely going on here. So when we look back on 2020, I like to say it's a combination of that, but then also for us, we've seen the increase of fentanyl going up. So how much was that? Just a continuation of that increase over time. So we like to say it's a combination. Definitely, but last year was very active. And then, getting into, I've briefly looked at, looking at social or the vulnerability index. So we've mapped that out of looking at which areas are more vulnerable per CDC, and then seeing how that maps in relation to where we're seeing overdose activity. And we definitely saw some overlap between that of certain groups that were affected during the months of the pandemic.
I think the only thing I would add to that is, I think sometimes in the public narrative, it's nearly an either or. It's kind of like, well, we should stop dealing with the the pandemic because look, it's causing all these overdoses, or vice versa. And and I think we try to go out of our way to say, no, it's both. Both need to be dealt with. The pandemic did not cause the addiction that brought these people to an overdose. That was there. Something else was going on, and that needs to be dealt with. So, it amplified something that was already happening. And we need to not lose sight of that and turn this into an either or proposition. And as Josh said, I think once we get out the other side of the pandemic, we're still left with the pervasiveness of fentanyl in the community. And that's still going to be killing people at a huge rate. Again, if we look back to 2016 and looked where we are today, yeah, this crisis escalated, and for the past year maybe hasn't been given the attention that it should be. We should have been dealing with two crises at the same time, but I think one got overshadowed by the other, which, you know, that makes sense. But I think some people might be shocked once eventually we release, you know, 2020 and 21 numbers of overdose.
Thank you.